And now it is a pleasure to introduce Dr. Kyle Stoller, and he'll be speaking to us about a gastroenterology update for midlife women. Thanks, Dr.
Well, I want to thank the organizers for having me here today. I am neither female nor middle-aged, but actually primarily take care of women in my practice, so very important group to me, and really happy to talk to you all today. I've followed Dr. Johnson before, and she talks about things, and I said that will kill you, and I'm going to talk about things that'll make you want to die, but won't necessarily make you want to kill. And so we're going to start up at the top, and we're going to move our way down in the GI system and get progressively more embarrassing. So let's start with GERD, and GERD is by many things heartburn, but it stands for gastroesophageal reflux disease. And it's really when reflux or acid contents from the stomach are coming up into your esophagus and are burning the lining of the esophagus, and that's causing symptoms. And that hallmark symptom is heartburn. And so that's that burning feeling in your chest. And if you've had it, you know what it is. It doesn't really take an explanation. If you haven't had it, there are many things that are blamed on GERD. A lot of times they don't end up being GERD. The most feared complication, both from my perspective but also from your perspective, is esophageal cancer. It's real, it does happen, and we'll talk more about that. This is just a reminder that, the reason that reflux is happening is not that your stomach is too acidic. The problem is this little muscle at the top of the stomach here, which is called the lower esophageal sphincter. It's a little valve. It is temporarily relaxing, and it's allowing acidic contents to come up into your esophagus. Your esophagus doesn't like having acidic contents there, and that's really the defect there. So many times we focus on acid, and that's what many of our treatments focus on, but it's not always necessarily the cause of really what's going on here. So the typical complication, you can have inflammation or sort of burning of the lining of the esophagus. That's what I see when I do an endoscopy on patients who have heartburn sometimes. Obviously, if the heartburn is long enough, if it's severe enough, if there are other factors that may play a role here, sometimes we see esophageal cancer. That can be scary, of course. And the risk of esophageal cancer goes up as you have increasing duration of heartburn and the frequency of heartburn. So the acid exposure in your esophagus, just like the sun, as Sandy was talking about, the acid is sort of similar. It causes changes to the cells and can lead to cancer. As you get older, your risk of esophageal cancer does increase. But the good news for this group here is that actually the biggest increases that we're seeing in esophageal cancer are actually happening in men rather than women. Reasons that we don't quite understand, but this is one of those cancers, unlike heart disease, where we're seeing more and more women affected, where we're not seeing as many women affected. But the most common complication is no complication. Many people have heartburn, and it's extremely common. And most people, I do lots of endoscopies, some that I think are appropriate, some that were referred I don't think that are appropriate, but most of the time I don't see anything. And these people really do still have heartburn. So the question is, what can I do? What can I do without medication to try and make myself not have heartburn? Well, I always have patients coming in and they feel guilty. They're like, yeah, I really like coffee, chocolate, alcohol, spicy foods, peppermint, fatty foods. And I say, well, I really like those too. But if those cause symptoms for you, then you should avoid them. But you don't need to avoid them if they're not causing symptoms. I mean, maybe you shouldn't have fatty food because you'll gain weight, but that's not my department. But it's not going to cause heartburn if you didn't have it already. It may make the heartburn you have worse, but I don't want you to beat yourself up over those foods if they're not causing trouble. But what can we do? Well, there are two things that in recent data has showed that have been important. The first, and slightly less important, but still important, is weight reduction and decreasing your body mass index, right? That's a measure of your weight standardized by your height. By a small amount can really decrease almost by half your risk of getting reflux. We always say, avoid late meals, maybe raise the head of your bed. Well, keep in mind, we've done research, we've looked, and we said as people have reflux, we sort of invasively put these probes inside people. Most of the people who have acid reflux actually have acid reflux during the daytime, which is kind of counterintuitive because gravity is working. There's a small percentage of people who actually have reflux at night. Those are the people who benefit from these types of things. Those people actually often have more severe esophagitis, but the vast majority of people with reflux are having it during the day. The most important factor here is to stop smoking. Just like factors pretty much for probably every other speaker today, smoking, although it's difficult to quit, does have an effect on this lower esophageal sphincter. It's a very severe risk factor for potentially having reflux. So what do we do for treatment? Well, we're all familiar with antacids. I love, just like Sandy, going into the aisle at the drugstore and looking at heartburn medication and laxatives. I spend a lot of time in those types of aisles. And, there's just so many different options. And it's very easy to sort of pick these out. And they work great for sort of minor symptoms. But as we move up the food chain here, now we get to H2 blockers. These are, and I use brand names because those are the only things that patients know, right, are Zantac, Tagamet, Pepcid. These work better than sort of the traditional Tums, Maalox type of thing. But if you're using them every day, then the effect can start to wear off over time. Now we get to the top of the pyramid. These are the proton pump inhibitors, and these are the darling of the news media lately, right? Every patient has been asking me about these, and don't worry, we'll get to them. But these are your things like your Prilosec, your Nexium, your Zegerid, your Prevacid. They're the most effective at reducing acid, and as a result, are the most effective at stopping acid reflux. If you do use them, they need to be taken on an empty stomach. Keep that in mind. They don't work as well, and that can be a reason why they're not working for many patients that I see for a consultation. Well, if these medications are so good, there has to be a downside. I always tell patients any medicine that works well probably has a side effect as well, and proton pump inhibitors certainly do. You know, people can get headache and diarrhea. You can switch the brand. Those will often go away. The ones that we've known about for a long time are GI infections. You know, if you think of your stomach like the sort of a molten lava pit, right? It's this barrier of acid where if you swallow a bad bug, a bacteria, it gets killed off by the acid, doesn't make it further down. If you decrease the acid in your stomach, you're probably going to increase your likelihood of getting infections. That's somewhat of a theoretical risk, but we have seen it in practice as well. Just remember, though, when you're taking these acid medicines, you still have a lot of acid in your stomach left. You actually need that for digestion. For particular people who are entering and going through menopause, we do need to think of this risk of fracture. And this happens because we're not absorbing calcium as well. So in a non-acidic stomach environment, you don't absorb calcium as well. And when you're already at risk for low bone density because of the loss of estrogen as you're getting age and going into menopause, and maybe for other reasons, family history of low bone density osteoporosis, we need to think about that. If you do need to be on one of these medications long term, and there are patients out there who really do need them, then you should probably be taking calcium citrate. Okay, most of the calciums that you get over the counter are calcium carbonate. Those are not as effectively as absorbed in a low acid environment. And this is something that's not necessarily well known in sort of other parts, even in the GI community, so it's something to think about and talk about. Now, recent studies, here's where we made the news. So PPIs, in no particular order, cause dementia, heart disease, and kidney disease risk. So that's scary. You know, I don't want to be demented, I don't want to have a heart attack, and I don't want to have kidney disease. I would get rid of the heart disease risk. That was actually a pretty poorly done study. I can't really make any conclusions from that. The dementia and the kidney disease risks, they're real though, but these were not where they assigned the patients, you take PPIs and you don't, and let's see what happens to you, right? That's the best kind of study. What these studies showed really were saying, we followed these people over time, and there was an increased risk of dementia and kidney disease in those people who were taking these medications. There's a lot of ifs, but of course doctors are always saying if, but, you know, we can never get a straight answer from a doctor. But what I do tell people is, you know, your absolute risk of having one of these things, it's like buying a lottery ticket. If you buy one lottery ticket, your likelihood of winning the lottery is unfortunately low. If you buy 2 lottery tickets, you are twice as likely to win the lottery, but unfortunately you're still not going to win the lottery. So the same thing happens here. You are unlikely to have these things happen to you, but there is that risk, and it is an important thing to talk about with your doctor. So how do you decide if these medications are right for you? So in general, both you guys and me, we're guilty of overprescribing these medications. They're available over the counter. Many patients take them for longer than it's indicated. And on the doctor's side, we prescribe too many of these. We give them out sort of like candy, and we don't take people off of them when we need to. If you are on one of these medications already, and chances are a good chunk of you are, because it's one of the most prescribed or purchased or used medications in the country, talk to your doctor about using a lower dose. The higher the dose, the higher the risk. A lowest dose in most of these medications is about 20 milligrams daily, and I think of all these medications as pretty much the same, no matter what the commercials are telling you. You should talk to your doctor about a trial coming off of these medications. But keep in mind, there's a caveat, right? These block acid pumps in your stomach from secreting acid. If you suddenly take the acid blocking medication away, all of the pumps turn on at once and have a big party. So they've actually given these medicines to people who don't have any stomach problems, and then they've suddenly taken them away, and they all developed heartburn. So you're all going to get heartburn if you stop these medicines, and it's like the perfect medication to sell, right? Because for a week, everyone's convinced you need this medicine because you feel so miserable. So you do need to use some of the other medicines that we talked about as a bridge. And if after a week or so you're still having those symptoms, then yeah, you're probably someone who's going to need to take this more regularly. If the PPI has not helped your symptoms at all, then you probably don't have heartburn. And these are the kind of medications that can stick around on a medication list for years. Doctors, patients don't do anything about it. If it's not helping you, then don't take it. But they are great medicines for the right patients, and these are people who have frequent heartburn that affects their quality of life. And by frequent, I mean at least 3 times a week, but you'll know if you're one of those patients because you're happier when you're on a PPI than when you're off. Damage to the esophagus, right? We see that esophagitis, we know we need it. And then people who have ulcers, that's sort of protecting the stomach. It's kind of a different ball of wax. So now moving down into the GI tract, we get into irritable bowel syndrome or IBS, really one of my favorite topics. But everything that doctors can't describe that has to do with bowel movements is attributed to IBS. And we should keep in mind that it actually has a diagnosis. It has a definition here. And it's recurring symptoms of abdominal pain, bloating, and a change in bowel habits. But the hallmark symptom here is abdominal pain. So if you're not having abdominal pain related to your bowel movements, you probably don't have IBS. You probably have something else, but not necessarily IBS. The key here is that it improves with defecation. And the onset is associated with the change in the form or the frequency of the stool, meaning when you feel that pain, your stools are getting looser or they're getting more firm, you're getting more constipated. This is IBS. So who has IBS? Well, it's an important topic to talk about because it's really 2 to 2.5 to 1 ratio. And I didn't originally start out as sort of a women's health and GI specialist, but I started out as an IBS specialist. And then I realized all my patients were women, so I said I might as well put on this hat as well. But many patients really don't come and get care. There's about 20%, so about 20% of this room has IBS. A smaller percentage of them will actually come and get care. But usually it's sort of someone who has a long history of a sensitive stomach, and then something kind of tips them over the edge, be it an illness, a stressor, something going on in their life. But usually things don't come out of the woodwork. So maybe it's not IBS, and this gets to the colon cancer question. If you're starting to have new symptoms coming out of nowhere at age 50 or older, and maybe even a little bit younger than that, unintentional weight loss, nocturnal diarrhea, right? People with IBS will often wake up and then have diarrhea, but if you have diarrhea that's springing you out of bed, that's generally not indicative of IBS. Anemia or low blood counts, bloody stools, and then family history of GI disease like colon cancer, celiac disease, or IBD, which often gets confused with IBS. IBD, inflammation, bleeding, IBS, no inflammation, generally benign. So celiac disease is something we talk about a lot. It's probably underdiagnosed in this country, probably has about a 1% prevalence in this country overall, but it's not so prevalent that everyone and every celebrity is going gluten-free, right? Not every one of those patients has celiac disease. So this is increasing popularity of going gluten-free and this villainization of wheat products, which is really a shame. And there's this question, is there increasing gluten content in foods? Are there changing in gut bacteria? And this leads us to the concept of non-celiac gluten sensitivity. It really should be non-celiac wheat sensitivity because gluten is the protein in wheat. That's what causes the allergy in celiac disease. But in people who are sensitive to wheat, it's really wheat. It's not the protein necessarily. So you don't have to necessarily be gluten-free, but wheat-free. But, for years, gastroenterologists told patients who were telling them, I feel sick after I eat certain things. It's in your head, relax. In truth, we have recent good data that there actually is this concept of non-celiac wheat sensitivity. These people do have real symptoms that can be both GI, but also things like a brain fog after you eat. And we've also found other foods, such as the FODMAPs, FODMAP, which have also includes wheat, which also can generate symptoms. And these are now an important part of therapy for the patients that I see. So IBS often gets a bad name, right? It's sort of the way among physicians, but also among patients as well, because people tend to dismiss it. But it has a big impact on quality of life. But, I always tell patients, IBS is a disease in your gut. Although it may be affected by what's going on in your head, it's not a disease of your head. But there's really this close interaction between your brain and your gut. And really, there's a problem where normal gut sensations are improperly amplified. So the nerves that are at the level of the intestine are sending signals, right? These telephone wires are sending improper signals to your brain that are saying, help, help, I'm in trouble. And your brain is doing what any car with a bad sensor would do. It's interpreting that data and it's reacting. So what I say, though, is that your brain, what's going on in your brain in your life controls the volume of symptoms. So many patients, when they're under stress, their GI symptoms get worse. And that happens even people who don't have IBS. That doesn't mean that these symptoms aren't real or legitimate. It just really means that your brain and your gut are really more closely interacted or connected. And to separate them is a little bit artificial. So for patients who have more than minor symptoms and maybe seeing me in the office, I always say treatment is sort of a three-legged stool, right? You take one leg away, the stool falls over. So the most common thing that we all do for patients and what you might do over the counter are motility agents, right? If you're going too much, you slow it down. If you're not going enough, you speed it up. But there's more to it here, right? Because there's this brain nerve action, we use what I call neuromodulators, but these are medicines that turn the volume down on the nerves in the GI tract. These may be antidepressants, but I want you to keep an open mind about that because these are low doses, often a tenth of the dose that we might use for depression or anxiety, and they can selectively target some of the nerves that lead to some symptoms. And finally, for patients who are open-minded about the role of their brain and what's going on in their life and how it plays into their GI symptoms, psychotherapy can be very effective and can be very helpful. And any patients who do the best are the people who sort of utilize all three of these treatments. Okay, now into constipation. We're moving further down into the GI tract. Talking about all the different treatments for constipation is really beyond the scope of this talk. But I want you to think of constipation not just as the amount of bowel movements that you have, right? Constipation, we know, is getting more and more common as you get older, much more common in women than in men. But in general, the way that most people think about the constipation that they have is they think, oh, I have a sluggish colon, that the stool is not moving from point A to point B. But in reality, we just talked about IBS, which can give you symptoms of constipation, and that's a problem of nerves. Maybe your stool moves fine. And then I want to introduce a third and exciting concept, which is obstructed defecation, right? And this is where your pelvic floor doesn't work properly, right? Your stool gets all the way to your rectum. It's made it. It's almost there, and then it can't get out the door, right? And this is sort of the straining, that sense of incomplete evacuation that many people have when they feel constipated. And patients will often tell me, it's like I'm pushing against a closed door. And that's exactly what you're doing. The muscles and nerves can get out of whack. They can actually be easily fixed with pelvic floor physical therapy. It's actually remarkably effective. But you can imagine there's this sort of symphony of muscles and nerves that happen when you have a bowel movement. You guys don't think about it, but I think about it all the time. And it's very specialized and it works very well, but it can go out of whack. And so it's just something to think about. As we lose estrogen, as we go into menopause, the whole pelvic floor can get a little bit out of whack, and it's something that we think about. But at the end of the day, most of us use laxatives, right, for treatment. And there's so many different laxatives. I love the laxative aisle at the grocery store because I like to see what my patients are buying because by the time they've seen me, they've already gone through all the different laxatives. So I like to see sort of what the brand names are, what kind of bottles they come in, how much they cost. Well, finally, we get to the most embarrassing, but maybe one of the most important topics. This is fecal incontinence. And I hope that many of you have not experienced this, but I know that some of you have. Because the thing is here, I tell this when I talk to other doctors, and I tell this when I talk to patients. You need to ask about fecal incontinence. Doctors, I know mostly not doctors here, you need to ask your patients, though, are you having leakage of stool? Patients, you need to ask your doctor, is it normal that I'm having leaking of stool? And the answer is no, it's not normal, but it's incredibly common. The problem is that, people might talk about their heartburn at the office, but no one is going to say that they had a bowel movement in their pants. And it's funny, right? But at the same time, you can imagine you're sitting in a presentation like this, and without your control, you have leakage of stool contents. It's terribly embarrassing. It's socially isolating. We shed a lot of tears in my office, but the patients with fecal incontinence are often shedding the most. And they really change their regimen. They change their jobs. Bad things can happen here. And we have things to help them, so you do want to ask people about that. Now, keep in mind, 9% of women, right, 1 in 10 have severe fecal incontinence, right? This is the kind where you are having difficulty getting out of the house without having accidents at least once a day. But you can see there's this age distribution. And as we get into this perimenopausal area, menopausal area, our rate starts to go up. So what's happening here? What did we do to our pelvic floor to deserve this? That's what we did. So in addition to that, adult child that's living in your basement, you also have the gift of fecal incontinence, okay? So what happens here, right? Most people have children in their 20s and 30s, right? And during that child process, that birthing process, there's damage to the pelvic floor. There's damage to the muscles that control and the nerves in the rectum and the anus. But because you're young, your body compensates for it. You don't even notice. But then, unfortunately, as we get old, as estrogen starts to wear off, those pelvic floor muscles are no longer quite as good as they once were. The nerves are no longer quite as sensitive or as responsive as they were. And all of a sudden, the patients that I'm seeing with fecal incontinence are really women who are in their 40s, 50s, and 60s. Okay, so it really is generally a consequence of childbirth. There can be other factors at play, but generally childbirth is sort of the major thing. It really kind of spoils the birth of my own children, I would say, thinking about this. Neurological problems. I would say many patients with neurological problems have issues with fecal incontinence, but most patients with fecal incontinence do not have neurological problems. These are things like Parkinson's disease, but also things like diabetes that tends to affect nerves. And then I do want to talk about inflammatory conditions or diarrhea, because you can imagine if your rectum doesn't hold stool very well and doesn't prevent it from coming out, you don't want to deliver stool to your rectum very quickly. So if you're having diarrhea, that's going to increase your risk for incontinence. And there is one disease, and I wish I put it in my slides, that actually is specifically targeting middle-aged, midlife women, and that is something called microscopic colitis. Right? This is an inflammation of the colon that is microscopic, meaning if I look in my colonoscope, I don't see anything. You don't see blood, but if I do biopsies, I can see that there's inflammation. This causes diarrhea that can often lead to fecal incontinence, often doesn't lead to fecal incontinence, and it's very easily treatable. But keep in mind, just because you had a colonoscopy, if you didn't tell your gastroenterologist that you're having diarrhea, they're not going to do biopsies for this, right? That's not part of the normal protocol. So just because you had a normal colonoscopy, if there weren't biopsies done, you haven't excluded this disease. So I want to end here and thank you, and then I'll take questions after the next speaker.